My name is Jinjun Chen from Hepatology Unit, Nanfang Hospital, Southern Medical University, China. I am very pleased to be here to share the preliminary data of PASTON study. The PASTON study is the first one trying to investigate TB therapy in clinical liver disease. This time, I will share the study design and the safety data of TB therapy in this ongoing study. As we all know, acute and chronic liver failure patients generally will suffer multiple organ injuries or organ failures. However, for lung failure or kidney failure, we have therapeutic options for all patients. And for liver failure, therapeutic plasma exchange and DPMAS are having more and more positive data. As we all know, the DPMAS working mode is including two categories. One is the BS330, which is for adsorption of total bilirubin bile acid. And the second one is the HA330-2, which is designed for adsorption of inflammatory mediators like middle molecular toxins. And in China, the popular modality of artificial liver support is, the first one is the therapeutic plasma exchange alone, and the second one is the DPMAS alone. Recently, DPMAS combined with therapeutic plasma exchange are much more preferred by clinical doctors. However, so far there is no prospective and large-size study on DPMAS in liver failure patients, and there is no prospective safety data on DPMAS combining with therapeutic plasma exchange in our patients. Therefore, we start a PASTON study at 2021. The PASTON study is a prospective multi-center and cluster-controlled study, which is focusing on to precise profiling of ACL patients and DPMAS therapy, try to find out who will be responsible for DPMAS therapy, and finally achieving a good endpoints. I am the leading investigator from Nanfang Hospital, Southern Medical University. At the beginning, we screened 57 teaching hospitals in the field of liver disease, infectious disease, and digestive disease across all China. We divide the scientists into DPMAS group, which has much more experience on the DPMAS therapy and plasma exchange therapy. And the other centers are divided into standard of care group, which is not very familiar with DPMAS or plasma exchange, or they do not have the devices. The sample size of PASTON study will be 1,300 patients, and 650 patients will be included into each group. This is the distribution of our research centers. We can see that all centers are across all China. The flowchart of PASTON study. The first thing is that we will screen adult patients with chronic liver disease, regardless of the etiology. The total bilirubin will greater than or equal to 12 milligrams per deciliter, and the international normalized ratio will be greater or equal to 1.5. For the exclusion criteria, the first is the patients with 3 or more organ failures. We consider patients with 3 or more organ failures will be much more suitable for liver transplantation rather than DPMAS or plasma exchange alone. The eligible patients will be divided into DPMAS group of standard of care group according to the centers they are treated in. And the primary outcomes of PASTON study include the 4-week mortality and or 4-week disease progression. The disease progression is defined as for the patients cannot be diagnosed as ACLF according to the ESO criteria, and the disease developed within 4 weeks or 3 months developed into ACLF. That will be defined as disease progression. The secondary outcomes of PASTON study includes 3 months mortality or disease progression. And we will follow up patients 2 to 48 weeks to look at the outcomes, the survival status, or liver transplantation status. The case schedule of our PASTON study includes, at the beginning, we will screen and include 1,300 patients. We will divide the patients into DPMAS group or standard of care group according to the centers they are stayed. At the baseline, we will collect samples including plasma, urine, and stool samples from interested centers for both DPMAS group and standard of care group. And for DPMAS group, we will also collect plasma samples just before and after the first DPMAS therapy. These samples will be centralized to our biobanks. We will follow our patients at 4 weeks and at 12 weeks closely to look at the survival status, liver transplantations, or disease progression. Due to January 5th, we have 24 active centers for DPMAS group and 25 active centers for standard of care group. Finally, we screen and include 641 cases into the DPMAS group and 475 patients into the standard of care group. And the following slides will show the centers, active centers' contribution to the DPMAS and standard of care group. I will show the very preliminary data of our patients in the DPMAS group, and we are working hard to clean and log the data, so this data will be changed sometimes. And for the baseline of 641 patients in the DPMAS group, the etiology is much more different from European patients, as hepatitis B infection is the majority cause of our chronic liver disease in our patients. And 25.3% of our patients can be diagnosed as ESO-ACLF. We then look at the DPMAS treatment mode. We see that only 22.1% of our patients are treated with DPMAS alone for the first DPMAS therapy. And the remaining 77.9% of patients are treated with DPMAS combining with therapeutic plasma exchange. That shows that the combination therapy mode are most accepted by our doctors. If we look at the number of DPMA therapies, we found that around 1/3 of patients are treated with a single DPMA therapy, and the other 1/3 of patients are treated with double DPMA therapies. And 20% of our patients are treated with 3 DPMA therapies in the study. The remaining 20% of our patients are treated with 4 or more DPMA procedures. That means that we do not have the consensus recommendations for the number of DPMA therapies in our liver failure patients. And if we look at the technical details for the first DPMA therapy in our patients, we found that the plasma treatment volume of the first DPMA treatment mostly is greater than 5,000 milliliters, and only 25% of patients with plasma treatment volume less than 4,000 milliliters. As we all know, liver failure patients always has coagulation injury or failure. However, we can see that only 4.7 patients, they do not have any anticoagulants in the first DPMA therapy. If we look at the blood cells counts before and after the first DPMA therapy, we found that the wild blood cells counts increased after the first DPMA therapy. And contrary, the platelet counts and hemoglobin levels significantly decreased with the first DPMA treatment. If we look at the treatment-related complications, we found that only 12.4% of our patients with significant adverse events, which includes consumable-related, like membrane rupture, coagulation in the cartridge, or in the dialyzer. Also includes the patient-reported adverse events like bleeding, lip pneumonitis, allergy, and hypertension, and others. However, we can see that 87.6% of our patients, they do not report the adverse events related to the DPMA therapy. So this is by far the biggest prospective data of DPMAs in liver failure patients. The DPMAs therapy shows a very good safety profile. And for the anti-clot strategy in the first DPMA therapy, we found that the heparin is the most commonly used, and the second one is a low molecular weight heparin or citrate. The in vitro clot found only 1.7 in patients treated with low molecular weight heparin, and 0 in the 58 patients treated with citrate as the anti-clot strategy. That will open the question that which anti-clot drugs is most suitable for liver failure patients. If we look at the immediate responses of first DPMA therapy, we found that the total bilirubin levels significantly decreased after the first DPMA therapy, which is around 100 micromole per liter. And if we look at the C-reactive protein levels or pro-CT levels, which both reflects the inflammatory conditions of liver failure patients, we found that both biomarkers decreased significantly after the first DPMA therapy, which shows that the DPMA therapy will ameliorate the inflammatory condition of our patients and balance their responses. We are closely monitor and follow up our patients. Hopefully, we will clean and log the primary and secondary outcomes data at November this year. Hopefully, I will have opportunity to share the outcome data in the future. We have the final case enrolled on April 15, 2023. Hopefully, we will finish all endpoints follow-up July this year, and if everything is okay, we will have the clean and logged data for the outcomes and other details. So next April, I will have opportunity share the data analysis. Finally, I will thank all my collaborators from the 47 centers and the Chinese Foundation for Hepatitis B as the sponsors, and the Jafron Limited, and the CRO company, and the CSC colleagues, and all my patients. Thank you very much.